Assalamu alaikum students. I'm Dr. Riaz Qureshi, cardiologist. Today I'm going to take your class on cardiomyopathy and pericardial diseases. Now, first of all, the definition of cardiomyopathy: a primary disorder of the heart muscle that causes abnormal myocardial performance. And it is not the result of disease or dysfunction other than cardiac structures like myocardial infarction, systemic hypertension, valvular heart disease, or valvular stenosis or regurgitation. So basically, primarily, it is a disease of the heart muscle, not due to any other cause. Now, the classification of the cardiomyopathy, we are going to discuss about the etiology, gross anatomy, histology, genetics, biochemistry, immunology, hemodynamics, functional prognosis, and treatment about the cardiomyopathies. WHO classification, first of all, the primary cardiomyopathy is mostly unknown cause. They are divided into three categories. Number one, dilated cardiomyopathy. Number two, hypertrophic cardiomyopathy. Number three, restrictive cardiomyopathy. The specific heart muscle disease secondary to infective endocarditis, metabolic diseases, systemic diseases, hereditary disease, sensitivity, and toxic. These are the secondary cause of cardiomyopathies. The functional classification of cardiomyopathies are dilated, which is also known as congestive or dilated cardiomyopathy, or idiopathic dilated cardiomyopathy, in which the ventricular enlargement and systolic dysfunction occurs. Second type is hypertrophic cardiomyopathy, which is also known as hypertrophic or hypertrophic obstructive cardiomyopathy. In the absence of hypertension, aortic stenosis, as you all know, hypertension and hypertrophy of the hypertrophic cardiomyopathy. Okay, this is also known as intracranial condition. The abnormal filling and diastolic function occurs. So these are the main three types. First of all, idiopathic dilated cardiomyopathies. So IDC or idiopathic definition, a disease of that increased heart size and weight. Ventricular dilatation occurs.
हेलो हेलो सर, आपकी आवाज में
जी जी
वॉइस में मसला आ रहा है आपकी।
आप सही आ रही है? अभी सही आ रही है?
हाँ, बहुत ज्यादा ब्रेक हो रही है।
देखिए, आपको सही आ रही है मेरी? यहाँ क्या आपको?
हाँ, अभी सही आ रही है, लेकिन अभी जो आप लेक्चर डिलीवर कर रहे, अभी सही आ रही है, लेकिन आप जब लेक्चर डिलीवर कर रहे थे उस वक्त आपकी आवाज बहुत ब्रेक हो रही थी। अभी भी देखें ब्रेक हो रही है आपकी आवाज। आपके शायद इंटरनेट कनेक्शन में कोई मसला लग रहा है।
मेरे पास तो बिल्कुल क्लियर आ रही है, चल रहा है, क्योंकि इसीलिए लास्ट क्लास ली है। So pathology, increase in heart size and weight. Ventricular dilatation normally occurs with normal wall thickness space. Now, incidence and cases per 1,000 occurs. Yes, तो अब मैं क्या करूँ बताऊँ? जी, मैंने नेट पे चलाया है। जी जी, मैं अभी इस पे बेसिकली मेरे पास 4G है, इससे चला रहा हूँ मैं। हाँ, LTE पे उसी पे चल रहा है। लास्ट क्लास भी मैंने 4G पे चलाया, क्योंकि घर की डाटा पे इसलिए चला था, उस पे जो है वो डिस्टॉर्शन बहुत होती है। तो मैं उस पर स्विच करूँ, फिर दोबारा से उसको कनेक्ट करना पड़ेगा या वैसे? चलिए मैं switch करता हूँ उसको इस पर.
जी अब सही है सर.
Now shall we continue?
जी बिल्कुल कंटिन्यू करें.
Okay. Now, incidence and prognosis, basically 3 cases per 100,000 used to occur. 20,000 new cases. This is basically all data taken from the USA. We don't have the proper data of cardiomyopathy. So the death and prognosis, progressive pump failure occur in 1 year 25%, and 2 years 35 to 40%, 5 years 40 to 8%. This stabilization observed in 20 to 50%. Complete recovery is very rare because it's a primary disease of the heart muscles. This is the curve which shows the survival rate of the 104 patient data over the years. This is basically taken from American Journal of Cardiology. This is not our data. Now, the prognosis of idiopathic dilated cardiomyopathy, the clinical factors which are most important: predictive, possible, and non-predictive. So predictive elements are symptoms, and in which hemodynamics, left ventricular heart failure ejection fraction is lower, heart failure occurs in LV size is normal or dilated. Dysarrhythmia occurs that can also lead to poor prognosis. Histopathology, hyponatremia, plasma, or non-epinephrine release is also basically poor prognosis. These are the predicting prognosis of idiopathic cardiomyopathies. Now, the clinical manifestation of cardiomyopathies, the highest incidence is occur in middle age. Blacks are 2 times more frequent than whites, and men's are 3 times more frequent than women's. Symptoms may be gradual in onset. In acute presentation, the misdiagnosis occur as a viral upper respiratory tract infection in young adults because the most cardinal symptoms is shortness of breath. Uncommon to find the specific myocardial diseases. That's why the myocardial biopsy is basically the most appropriate diagnostic test for the cardiomyopathies. The history and physical examination, symptoms of heart failure occurs, basically the pulmonary condition that's caused by left ventricular heart failure, which leads to dyspnea, rest, shortness of breath, exertional dyspnea, or nocturnal dyspnea may occur. Orthopnea can also occur. Systemic congestion occurs due to the right heart failure, which leads to edema, nausea, abdominal pain, and nocturia. Low cardiac output leads to fatigue and weaknesses. Hypertension, tachycardia, tachypnea, and raised GVP also used to seen in these kind of patients. For the diagnosis, we do the cardiac imaging. First of all, we get the XHS. In XHS, we might be seeing the dilated heart. Do electrocardiography. In electrocardiography, we used to see the small complexes due to dilatation or irregular complexes. We also do ambulatory Holter monitoring because in that patients, the most common symptom is palpitation due to arrhythmias. That leads to lightheadedness, palpitation, and syncope. And most appropriate diagnostic test, which helps in the diagnosis, is two-dimensional echocardiography. So when we do the echocardiography, we easily diagnose the dilatation of all 4 chambers and poor ejection fraction that leads to low cardiac output. Radionuclide ventriculography also done, cardiac catheterization if patient is more than 40 years to rule out the ischemic heart disease and high profile risk. Clinical indication for biopsy, basically, if we are confirming our diagnosis, we used to do the biopsy, which is also known as endomyocardial biopsy. The definitive, basically, to monitoring the cardiac allograft rejection. First of all, if you are planning to transplant the heart, so we must do biopsy to rule out the heart rejection. Second thing is monitoring the toxic drug and anthracycline cardiotoxicity. The possible indications are detection and monitoring of the myocarditis, diagnosis of secondary cardiomyopathies, differentiation between the restrictive and constrictive heart disease. So these are the possible endomyocardial biopsies. Now, the management of dilated cardiomyopathy, first of all, limit the activity based on functional status. So we have to find out the functional classification of the patient according to dyspnea. It's the New York heart fluid restriction. Salt restriction up to 2 grams, fluid restriction for significant low sodium. Initiate medical therapy, which includes ACE inhibitors, digoxin, beta blockers, and dilators, which are hydralazine and nitrates. Consider adding the beta blocker agents if the symptoms persist. We also suggest anticoagulation if patient having an ejection fraction less than 30% and a history of thromboemboli, presence of neural tumors. Intravenous dopamine, dobutamine, or phosphodiesterase inhibitors are also recommended in patients who is having low blood pressure and low cardiac outputs. Maintaining all these above medical therapy, the cardiac transplantation is recommended. Second type is hypertrophic cardiomyopathy. Zero to 2.2%. The hypertrophic and non-dilated left ventricle in the absence of any other disease. So whenever we found a hypertrophic muscles of the myocardium, first thing we have to rule out all secondary causes like hypertension, aortic stenosis, and shunts. So then, if all secondary causes are excluded, then we label as a hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, left ventricle cavity is small, asymmetrical septal. Sometimes the mitral valve leaflet that cause dynamic obstruction, which is also known as hypertrophic obstructive cardiomyopathy. So these are the pictures of hypertrophic cardiomyopathy. Here you can see in upper left first picture, you can see the hypertrophy of the septum only, which is also known as asymmetrical septal hypertrophy. And upper right, you can see the symmetrical hypertrophy of the left ventricle all over. Now in lower left, again, asymmetrical hypertrophy, again, with the systolic anterior motion of the mitral valve, which causing the dynamic obstruction of the left ventricular outflow tract. And this type of hypertrophy is also known as hypertrophic obstructive cardiomyopathy because there is obstruction in the outflow. Fourth one, lower right picture, which shows the apical hypertrophy. Here you can see it is apex is more pronounced. This is known as apical hypertrophy. These are the images taken from the echocardiography. Upper left first image shows the septal hypertrophy. Upper right again septal hypertrophy, and lower short X is also showing hypertrophy. And here lower right, which we can see the AM mode, which is also showing the dynamic obstruction of the hypertrophy. Septal leaflet is moving towards the septum. Hypertrophic cardiomyopathy may occur in a familial pattern, first reported by Sidman et al. In 1989. It occurs as an autosomal dominant in 50% of the patient. 5 different genes on at least 4 types of chromosomes with over 3 dozens of mutation occurs. So here these are the 4 types, and chromosome 14, chromosome 1, chromosome 15, and chromosome 11. The mutation used to take occur on these chromosomes. And the hypertrophic cardiomyopathy used to occur in families. If you found a patient who's having hypertrophic cardiomyopathy, you must recommend to do the echo of the whole family to rule out the familial hypertrophic cardiomyopathy. What is the pathophysiology of hypertrophic cardiomyopathy? Basically, during systole, it's dynamic obstruction of the outflow tract occurs. That causes the obstruction of the outflow that leads to low cardiac output. And in that such cases, sudden death used to occur, or patient might be complaining of angina. In diastole, impaired diastolic filling pattern occur, and that leads to increased filling pressure in the left ventricle and left atrium. That leads to myocardial ischemia. Increased muscle mass is one of the cause of the myocardial ischemia that used to increase the left ventricular filling pressure and oxygen demand. Decreased vasodilator reserve that leads to capillary density and abnormal intramural coronary arteries. Systolic compression of the arteries takes place due to the hypertrophy. Clinical manifestation. First of all, may we find it's asymptomatic patient, and on echocardiography we find that patient having a hypertrophy, but patient is asymptomatic. But in symptomatic patient, the most cardinal symptom is dyspnea. Second one is the angina. Because of the hypertrophy, patient used to complain of chest pain on exertion. Fatigue, pre-syncope and syncope increases risk of sudden cardiac death in children and adults, because angina, fatigue and syncope, these are the symptoms which leads to increased risk of sudden cardiac death. Palpitation, proximal nocturnal dyspnea, congestive heart failure, dizziness are less frequent. These are the procedures we can do while during diagnosis and all other things. We'll discuss it later on. These are the Valsalva, and basically these are the tests which we discuss on bedside examinations also. The natural history of hypertrophic cardiomyopathy, the annual mortality is 3% in referral centers, probably closer to 1% of all patients. The risk of sudden cardiac death is higher in children, may be as high as 6% per year. Majority have progressive hypertrophy. Clinical deterioration usually slow. Progression of dilated cardiomyopathy occurs in 10 to 15% of the patients. The risk factors for sudden cardiac death: young age patient less than 30 years, malignant family history of sudden deaths, gene mutation prone to sudden deaths, aborted sudden cardiac deaths, sustained VT or SVT, recurrent syncope in young patients, non-sustained VT on Holter monitoring, bradyarrhythmias. These are the risk factors for the sudden cardiac deaths. Recommendation for athlete activity: avoid most competitive sports, whether or not symptomatic or outflow gradient are present or not. So if you diagnose a patient who's having a hypertrophic cardiomyopathy, the athletic activity must be avoided. The low-risk older patient more than 30 years may participate in athletic activity if all of the following are absent. Recommendations for athletic activity: low-risk older patients more than 30 years may participate in the athletic activity if all of the following are absent. Ventricular tachycardia, Holter monitoring, family history of sudden death due to hypertrophic cardiomyopathy, history of syncope or episode of impaired consciousness level, severe hemodynamic abnormalities, gradient more than 50, exercise-induced hypotension, moderate to severe mitral regurgitation, and large left ventricle to left atrium more than 50, proximal atrial fibrillation, abnormal myocardial perfusion. These are all factors may participate in the sudden cardiac death in patients more than 30 years. The management of hypertrophic cardiomyopathy: first of all, the beta blockers, calcium channel blockers, disopyramide, midron, sotalol, dual chamber pacemaking, myotomy. If there is an obstruction at the outflow, you can perform myotomy of that muscle that relieves that obstruction. Application of the anterior muscle valve leaflet. If mitral valve anterior motion takes place, repairment of the myocardial muscle cells can also improve the survival. Now, hypertrophic cardiomyopathy versus aortic stenosis, because when hypertrophic obstructive cardiomyopathy takes place, it has same symptoms which occurs in aortic stenosis. So how we differentiate between hypertrophic obstructive cardiomyopathy versus aortic stenosis. Carotid murmur takes place. So in hypertrophic cardiomyopathy, it spikes and burns. And in fixed obstruction, like aortic stenosis, the pulse may, you all know about the parvus apparatus, slow rising and slow decline, radial pulse. So hypertrophic cardiomyopathy increases Valsalva standing, murmur increases, and the murmur or obstruction decreases on squatting and hand grip, decreases on passive flag elevations, systolic thrill on left fourth intercostal space. We found in hypertrophic cardiomyopathy, and in aortic stenosis, we found the murmur at second right intercostal space. Systolic click is absent in hypertrophic cardiomyopathy, but present in aortic stenosis. Other causes of hypertrophy, we also look for the other causes. Clinically mimics like have glycogen storage, infant with diabetic mother, amyloid diseases, genetic condition like Noonan, Friedreich ataxia, familial restrictive cardiomyopathy with this array, exaggerated physiological response, Afro-Caribbean hypertension, old age hypertrophy, and athletic heart. So we have to look for these secondary causes to rule out the primary disease or secondary. Hypertrophic cardiomyopathies versus athlete heart. Most of the persons who are athlete, they have same hypertrophic heart. So we have to differentiate between the true hypertrophic cardiomyopathy and acute. So unusual pattern of left ventricular hypertrophy occurs in hypertrophic cardiomyopathy, not in acute heart. Left ventricular cavity size is less than 45 millimeter occurs in hypertrophic cardiomyopathy, not in acutes. Left ventricular cavity more than 55 millimeter we found in athletes, not in hypertrophic cardiomyopathy. LA enlargement only found in hypertrophic cardiomyopathy. Bizarre ECG pattern only found in hypertrophic cardiomyopathy. Abnormal LV filling present in hypertrophic cardiomyopathy. Female gender present in female hypertrophic cardiomyopathy. Decreased thickness with deconditioning occurs in athlete. Family history only occurs in hypertrophic cardiomyopathy, not in athletes. Hypertensive hypertrophic cardiomyopathy of elderly. As I told you, the hypertension is also one of the causes which leads to hypertrophy of the myocardium. The characteristics are modest concentric left ventricular hypertrophy. Should be less than 22 millimeter thickness. Small size LV cavity associated with hypertension. Ventricular morphology greatly distorted with reduced outflow obstruction. Sigmoid septum, which is also known as Granma-San, systolic anterior motion of the lateral. Now, the third type of hypertrophic cardiomyopathy is restrictive cardiomyopathy. As with the name, restrictive means the cavity is restricted to receive the volume. Now, the restrictive cardiomyopathy, the hallmark is abnormal diastolic function. The rapid ventricular filling will rigid ventricular walls with impaired ventricular filling. Bears some functional resemblance to constrictive pericarditis. So it has symptoms resemblance to constrictive pericarditis. Importance lies in its differentiation from operable constrictive pericarditis, because the constrictive pericarditis may be treatable after removing the pericardium. Exclusion criteria, again, we have to exclude all secondary causes. Left ventricular and diastolic dimension more than 7 centimeter. Myocardial wall thickness more than equal to 1.7 centimeters. Left ventricular and diastolic volume more than equal to 150 ml per meter square. Left ventricular ejection fraction less than 20%. These are the exclusion criteria for the restrictive cardiomyopathy. Now, the classification, restrictive may be called idiopathic. Second cause may be myocardial infiltrative or non-infiltrative disease. Non-infiltrative disease, again idiopathic, scleroderma. Infiltrative, like amyloid diseases, sarcoid, Watchers, Hurler diseases. Number third is storage disease like hemochromatosis, Fabry's, glycogen storage. Endomyocardial causes the endomyocardial fibrosis, hypereosinophilic syndrome like carcinoid syndrome, metastasis, malignancies, radiation, and anthracycline. These are all infiltrative causes of restrictive myocarditis. Clinical manifestations of restrictive cardiomyopathy, symptoms of right and left heart failure. JVP is raised, which is in which prominent X and Y descent. Echo again is the most diagnostic tool for the cardiomyopathies. In echo, abnormal mitral inflow pattern. Inflow basically is significance of filling pattern of the left ventricle or right ventricle. So we used to monitor the inflow pattern of the ventricles. So there must be a prominent E wave, rapid diastolic filling, and reduced deceleration time that leads to increased LA pressure. So consecutive restrictive pattern. So when we do the hemodynamics of the left ventricle, we see the pressure changes with these graph that shows the square root sign. Here you can see the square root sign in the yellow. It's significance of consecutive or restrictive pattern. Again, this is a pattern of JVP, X and Y descent. You can see X and Y descent in RA pressure, more pronounced X and Y descent, and the square root sign. Now, how we differentiate between restriction and constriction? Restrictive cardiomyopathy is itself a disease of the myocardium, and constriction, it is basically a disease of the pericardium. So how we different, both have same symptoms and same classifications. The history can provide the important clues. In constrictive pericarditis, the history of tuberculosis, trauma, pericarditis, collagen vasculars, it's not collagens, sorry for the mistake, collagen vascular disorders. In restrictive cardiomyopathy, amyloidosis, hemochromatosis, and in mixed pattern, mediastinal radiation, cardiac surgery. Restrictive cardiomyopathy treatment is non-satisfactory medical treatment. The drug therapy must be used with caution. Diuretic for extremely high filling pressures. Vasodilator may reduce the filling pressures. The role of calcium channel blocker may improve the diastolic compliance. Again, you have to use very cautiously. Digitalis and other inotropic agents are not indicated because muscle mass is restrictive, not receiving the volume. There is no need to give inotropics. Now, pericardial disease. Any question about cardiomyopathies? We are going to proceed pericardial disease. If you have any question, you can ask. Hello, you can hear me. Now, the pericardial diseases. So, pericardium, you all know that it has fibrous pericardium and serous pericardium. Serous pericardium has two layers, that is a parietal pericardium and vestral pericardium. The pericardium is the outer layer of the heart, which protects the heart and which anchors the heart inside the bag of the pericardium. The pericardial space, the space between parietal and vestral pericardium. And in that space, there is a fluid which provides a frictionless environment during contraction and relaxation. Around the RV and LV, ellipsoid structures confirming the left ventricular apex. Pericardial spaces, basically it's the space around the pulmonary and systemic venous inflows, and around the great vessels, the pericardium is to close the end of the sac and pericardial effusion. So basically, these are the spaces are where the great vessels are leaving the heart and the veins are entering into the heart. It is where the spaces used to occur. There are sinuses, pericardial sinuses, transverse sinus and oblique sinus. So here is the picture which shows when we remove the heart from the pericardium, and these are the vessels which are entering and exiting the heart. So it's a space used to take place. It's oblique and pericardial transverse space. This is a color picture again. You can easily see the four pulmonary veins, inferior and superior vena cava, aorta, and pulmonary trunk. So there is space lying in between these structures and these structures are entering into the heart. Now, what is pericarditis? Pericarditis is the inflammation of the pericardium. What are the causes? Causes are infection, maybe viral bacteria, trauma, uremia, transmitter, and infarct. In pericarditis, patient used to complain of chest pain. Easy changes may take place. The area for the diagnosis of pericarditis. Pericardial effusion may not be present. Pericardial effusion pericarditis bacterial or tuberculosis. One of the causes for pericarditis direct extension into the lungs and breast. Primary cardiac malignancy also post cardiac surgery. Pericardial effusion, basically intracardiac pericardial communication, blunt or penetrating chest trauma, post-catheter procedure, or left ventricular rupture. These are also causes of pericardial effusion, like blunt trauma, penetrating lesion, or while doing procedures, inserting a catheter also leads to pericardial effusion. The echocardiographic findings to rule out the pericarditis, the pericardial effusion may not be present, pericardial thickening may not be present, or sometimes we find entirely normal echocardiography. Pericardial effusion basically seen as an equilistant space around the heart. This is the picture which shows the pericardial effusion. Here you can see the muscles, and at the bottom of this picture you can see which is labeled as PE, pericardial space. This is a blackish shadow which shows the pericardial effusion, which is significance of accumulation of the fluid in the pericardial space. This is the short axis view. Again, here you can see the left ventricular cavity in the middle. At the bottom, you can see a blackish area which is showing that effusion is all around the heart. Now the pericarditis. Pericarditis basically is the pericardial thickening. Increase the echogenicity of the pericardium reflection onto the imaging. When we do the echo, we see the increased echogenicity of the pericardium. The multiple parallel reflection posterior to the left ventricle on M mode recording. So the pericardium is the outer layer. When we do the echocardiography, we see the higher reflection of the pericardium and see the parallel reflection at the posterior surface of the heart like this. here you can see with the arrow, these arrow shows the whitish pericardium, which is more pronounced, more brighter than normal structures. So that is the sign of pericarditis. Pericarditis is the clinical diagnosis that cannot be made independently on echocardiography. You have to be clear that pericarditis could be diagnosed on multiple factors, but most commonly it is diagnosed on the clinically. The goal of echocardiography is to evaluate for the pericardial effusion or thickening. Now, we do echo to rule out is there any pericardial effusion or not, or how the pericardium is thickened. Now, what is pericardial tamponade? Basically, pericardial tamponade occurs when the pressure in the pericardium exceeds the pressure in the cardiac chamber, resulting impairment of the filling. So that means that the pressure in the pericardial space is greater than the pressure into the left ventricle. So that leads to improper filling of the left ventricle. So the physiological consequences of the fluid in the pericardial space depends on volume and rate of accumulation. So tamponade basically occurs on the volume and rate of accumulation. If there is a rapid accumulation take place, so tamponade used to occur rapidly. If there is a very slow rate of effusion occurring, so there are chances of tamponade is low. As the pericardial pressure increases, the filling pressure of each cardiac chamber is subsequently impaired, with the lower pressure chamber most commonly affected. First, that these are the atria. Atria are the low pressure systems before the higher pressure system issue. So first, when the pericardial fluid takes place, it affects the low pressure system like atria. Then it affects the high pressure system like ventricles. The comprehensive effect of pericardial fluid is seen most clearly in the phase of the cardiac cycle when the pressure is lowest in the chamber. So the systolic is for the atria and diastolic for the ventricles. So in systole, the lowest pressures are in the atria, and in diastole, the lower pressures are in ventricles. In response to increased pericardial pressure, the filling pressure becomes elevated as a compensatory mechanism to maintain the cardiac output. In fully developed tamponade, all four cardiac chambers are equal and elevated due to exposure of entire heart to the elevated pericardial pressure. So in a full-blown tamponade, so all four chambers are compromised to the full-blown or high amount of pericardial fluid. The clinical findings are, first, the most important clinical finding is low cardiac output due to the improper filling of the ventricles, hypotension, tachycardia, raised JVP, pulses paradoxic. Pulses paradoxic is the cardinal symptom of the pericardial effusion or cardiac tamponade. There is inspiratory decline more than 10 mm of systolic blood pressure while taking the blood pressure. Now, constrictive pericarditis. Pathology. Visceral and pericardial, parietal pericardium are adherent, thickened, and fibrotic in constrictive pericarditis. Etiology of constrictive pericarditis is surgery, post-surgery, radiation therapy, repeated episodes of pericarditis. It means repeated episodes of infection which leads to pericarditis is also one of the cause of constrictive pericarditis. Radiation therapy is also one of the most common cause. Clinical symptoms: fatigue, malaise due to low cardiac output, elevated JVP, distant heart sound. While doing auscultation, you will hear heart sounds from very far, ascites and peripheral edema. Physiology: impaired diastolic cardiac filling due to abnormal pericardium, result in rapid early diastolic filling. Pressure changes: a brief rapid fall in ventricular pressure in early diastole, followed by high early diastolic pressure plateau. The dip plateau or square root sign is present. Rapid descent of right atrial pressure with the onset of left ventricular filling Y descent. Pressure changes basically only modest elevation of right ventricular pressure and systolic pulmonary artery pressure. The right ventricular diastolic pressure plateau that is one-third of the mode or systolic pressure. The equalization of the diastolic pressure in the right ventricle or left ventricle even after the volume loading condition. So these are the basically pressure changes which occur secondary to the involvement of the pericardium, which leads to increased pressure in the pericardial space that effects on left ventricular filling and cardiac output. So this is all about the cardiomyopathies and pericardial diseases. So any question regarding pericardial diseases or cardiomyopathies you can ask. Anybody is having any question regarding cardiomyopathies? From now, you all know that the cardiomyopathy is the primary disease of the heart. Whenever you are going to label cardiomyopathy, first thing is to exclude all secondary causes. You must know about the secondary causes of cardiomyopathies. Let's suppose a patient having a hypertrophy, so you have to exclude all secondary causes of other hypertrophy, like hypertension, aortic stenosis, shunts, and all of that. Because if aortic stenosis or hypertension is present, you cannot label as a cardiomyopathy because that hypertrophy may be due to the hypertension. So that's why I'm saying that the cardiomyopathy is the primary disease of the heart muscle. And I explained about the cardiomyopathy. There are three types: hypertrophic, dilated, and restrictive. Anybody who's having question regarding hypertrophic cardiomyopathies or pericardial diseases? Any question you can ask?